Good day everyone, I am Victor, the moderator for this webinar. I welcome everyone for today's webinar, which is CMS Physician Final Rules for 2024. Find out what CMS has finalized from proposed rules. I would now like to introduce our presenter for today, Jan Rasmussen. Jan Rasmussen, PCS, ACS OB, ACSGI. As a healthcare consultant, Jan has over 45 years of experience in physician billing, reimbursement, and compliance. I would now like to hand over the floor to the speaker. Over to you, Jan.
Thank you and welcome everyone. Today we've got a lot to go over and a lot of it is brand new and brand new to me also. I did a lot of searching on the final rule and looking at all the guidelines and hopefully I've given you enough information to be able to work with this in 2024. Basically what we have with the problem in 2024 is the physician fee schedule rate setting. There has to be neutral. The conversion factor this year is decreased by $1.15 to 32.74. So let's first talk about E&M issues. New code G2211 added to the services for E&M issues. Originally it was introduced back in 2021. Basically the concept is holistic patient-centered care. The provider is working to build that important relationship with the patient. It is not payable with an E&M service where there's a modifier 25. There are no specific documentation guidelines. Acute visits, again, where they're not following up or coordinating primary care for all their chronic conditions. Acute care only when G2211 might be not reported. The next thing we're going to talk about is split shared care. Office and outpatient visits 99202 through 99215, if they're in a facility setting, CMS requirements originally for 2024 were supposed to be based on total time to determine the substantive portion. Services may include both face-to-face and non-face-to-face activities. Critical care services can only be reached on time. They can only be billed based on time. Global maternity services include significant numbers in E&M services. Caregiver training. Basically, a caregiver is a person who works with or helps care for someone that has illness, disabled, or aged. Recognizing, CMS is going to recognize two existing CPT codes, 96202, Multiple Family Group Behavior Management Modification Training. For caregivers, patients may require assistance with challenging behaviors. 97550, Caregiver Training and Strategies and Techniques, and 97551 is each additional 15 minutes. Now, 97552 is a group training. These are not on the telehealth list. None of these codes were added to the telehealth. Caregivers be trained in positive behavior management strategies. Medical necessities should determine the volume and frequency of the training. All right, we have some other new auxiliary service and very, very extensive. There's two types of services that may be provided by auxiliary personnel. So social determinants of health risk. Basically, this new code, G0136, is administration of a test to standardized evidence-based assessment up to 15 minutes, and it cannot be performed more than once every 6 months. Okay, based on the practitioner's judgment as to whether it is necessary to initiate a risk assessment, physicians have a sixth sense, or QHPs have a sixth sense about these kind of things, and they need to document the medical necessity when they suspect this. It's a standardized evidence risk assessment tool, tested and validated through research, and includes food insecurity, housing insecurity, transportation needs, utility difficulties, that type of thing. It can also be billed in addition to an annual wellness visit as optional. It's not required for an annual wellness visit, but it's an optional additional element. Allow behavioral health practitioners to do this also. Intervention codes 90791 is your psychiatric diagnostic evaluation, and the behavioral health codes go from 96156 to 96168. In most cases, they don't expect the G0136 to be performed in advance of an associated E&M or behavioral health visit. And I've given you a possible evidence-based tools. They're not finalizing the issue of once they've identified social risk, you're supposed to use, or they're encouraging to use, to the Z codes in ICD-10 to identify those needs when you build that initial assessment. All communication with the patient has to be appropriate to the patient's education, developmental, and health literacy levels, and also culturally and linguistically appropriate. Now here's the CHI, Community Health Integration. There's two codes that really are to be performed to help those patients. G0019 is Community Health Integration Services performed by a certified or trained auxiliary personnel. The first one is G0019 and the second one is G0022. The initiating visit by the provider is billed separately, and the focus of CHE services would be addressing the SDOH needs that are interfering or presenting barriers to diagnosis and or treatment. They're also providing practitioner, home, and community-based care coordination. They're coordinating care transitions among different healthcare professionals. They're also providing education to that patient so they can understand what the problem is, help the patient meet their goals and preferences. Last of all, leveraging living experience. The billing practitioner is the physician, and they may have CHA services. They must meet all the incident to and other requirements and conditions for payment. So here's an example. The auxiliary personnel tailors support. Auxiliary personnel who provide CHI must be trained to perform, certified or trained. Training has to include competencies of patient and family communication. What needs to be documented? Only one practitioner can bill per calendar month. And now we're moving into principal illness navigation. The navigation billing is following an initiating E&M visit addressing a serious high-risk condition. TCM services may be initiating visit. E&M visits such as inpatient observation visits were not typically served as PIN, skilled nursing facility visits. Basically, it's one serious high-risk condition expected to last at least 3 months to put a patient at significant risk for a hospitalization. Some of the conditions may be cancer, chronic COPD. It requires development, monitoring, or revision of a disease-specific plan of care. The two new codes are G0023, Principal Illness Navigation by certified or trained auxiliary personnel, and then G0024 is an additional 30 minutes. You have to meet the 60 minutes before you go to the additional 30 minutes. So they had developed two new codes specific to peer support specialists, and that's G0140 and G0146. We're going to talk about those. G0140 is peer support principal navigation. It includes a person-centered assessment, coordination of receipt of needed services, health education, providing patient with information resources for clinical trials. Now, you're going to see with G0140 and G0146, now, they assist. They do not communicate directly with practitioners, developing and proposing strategies to help meet personal-centered goals, leverage of knowledge by the basic peer support. Auxiliary personnel who provide PIN services must be certified and trained, as we talked about before. Training regulations by state. It requires an initiating E&M service, just like your CHI does. Only one practitioner, again, the same thing. They want to make sure that there's a single point of contact. Approximately 48 states have professional certification programs for peer support services. Times furnishing the PIN services. Proposing a billing practitioner may arrange to have PIN services provided outside, again, as a community-based organization. Basically, PIN is best suited for a situation when the navigator can serve as a point of contact for the patient. They can be provided in addition to the other care management, just as CHI. All right, we're going to talk quickly about telehealth. Telehealth services furnished to patients in their homes. Expansion of the definition of telehealth practitioner. They also added health and well-being coaching services to a temporary telehealth list. Keep therapy services on the Medicare telehealth service. Continued payment for telehealth when furnished in RHCs and FQHCs. Telehealth teaching physicians. They're going to allow institutional providers to bill for outpatient therapy. Also, opioid treatment programs can bill under the outpatient benefit. Okay, behavioral health services. Consolidated Appropriation Act added payable providers to the Medicare physician fee schedule, implementing payment rules for 90839 psychotherapy crisis. Health behavioral assessment intervention and any successor codes may be billed by these social workers, adjusting the work fee RVUs for psychotherapy codes paid under the PFS. Current regulations for remote therapeutic monitoring, RHC and FQHC. Again, they're delaying the in-person requirements for mental health visits, include remote physiological monitoring and the remote therapeutic monitoring and general care management. Some of the last finalized rules. When we had the public health emergency, Medicare extended additional payment to administration. Now they've decided to extend additional payment for 3 preventive vaccines that they recognize. They've expanded the coverage of diabetes screening to include the hemoglobin A1C test. Also, they expanded the payments for dental and oral health. Discarded drugs, JW, is a modifier that used to report the amount of a drug that is discarded. Also, they're including timelines and the new guidelines for initial and subsequent discarded drug refund reports, clarifying the JW modifier does not apply to Medicare Advantage plans. So with that, thank you all for attending, and I hope you have a great day implementing all of these changes.
Thank you, Jen. That does conclude the session for today. Thank you everyone for participating. You may all disconnect now. Have a great day ahead.